Hello, my name is A.B. Mendelson, and I am an associate professor here at UCLA Head and Neck Surgery, and I also serve as the director of robotic surgery here. Today we're going to have a brief lecture on the up-to-date review of robotic surgery as it pertains to the otolaryngologist or head and neck surgeon. Before we get going, I want to review some of my own personal disclosures and conflicts of interest. I have been paid by Intuitive Surgical for my role as a surgical trainer and robotic proctor. I've also received research grant funding from Intuitive Surgical, as well as received travel funds from Med Robotics. With that aside, let's review our agenda today. What are we going to cover? Well, we will cover why robotic surgery should be understood by all otolaryngologists, not just head and neck cancer surgeons. We will review some of the current robotic surgical systems, as well as discussing what really is head and neck robotic surgery. And then we'll talk about some of the futuristic applications which we should be seeing within the next several years. What will this discussion not cover? It will not discuss robotic surgical techniques. I will not cover how to cut out a tonsil cancer or a tongue cancer. I will not discuss how I do it in terms of postoperative management. We can save all those things for another date. Similarly, I will not be reviewing any data or graphs for the most part. We're going to discuss mainly philosophy and why robotics is an important part of your practice as you're coming up. Let's go. Why head and neck robotic surgery? Well, let's make a case for surgical robotics. I'm taking an excerpt from an online article making a case for warehouse robotics. We can make small edits to an excerpt. We can say many people hear about warehouse. Well, many people hear about surgical robots and think it's too futuristic. Yet, they are really not theoretical. Some may scoff at this technology, but we think it would be a mistake to say that will never apply to my practice. So instead of boxes, let's consider an example instead from our field of otolaryngology. And for that, we'll need to go back a few years. Back to 1985, this photo showing a young Bruce Springsteen playing Wembley Stadium in London. And in this year, if someone came back with recurrent headaches that wasn't treated well with Tylenol, ultimately found to have chronic sinusitis, they required either a pretty large and invasive surgery from the outside or a bunch of surgeons crowded around the nose with a headlamp looking in, trying to remove as much sinus tissue as could safely be removed. Later that year, in 1985, the advent of endoscopic sinus surgery really hit the United States. What it did was it brought in cameras and microscopic instruments in order to visualize and access recessed areas of the head and the skull base. The endoscopic sinus surgery develops a surgical tool or approach to address multiple diagnoses. So it wasn't specifically just to treat nasal polyps, it was to access an area which we really had poor answers to. But not everybody was pleased about this. In a rebuttal letter to the Archives of Otolaryngology, published in 1986, this article or letter wrote, "With profound experience, it can take 4 hours to explore and treat these sinuses. How effectively then can this be done under local anesthetic?" And they claimed reduced time and not in an anticipated long-term complications. It would seem logical to pursue the method of open exposure that has less risk and is far more thorough. Hopefully it will not take 40 years before this method of endoscopic sinus surgery is abandoned. This author was guilty of a confirmation bias. What I do is by definition correct. It's tried and true. There is no way to make this any better. And so just the very change therefore makes it wrong. Thankfully, that author was proven incorrect, and we've seen a massive success of sinus surgery. So much to the point that today there are as many endoscopic sinus surgeries performed as gallbladder surgery. And what we saw was the successful adaptation of this visualization access. It leads to now was the standard of care, and most folks seeing those earlier pictures of traditional sinus surgery without the endoscope should hopefully have cringed quite a bit. So, robotic assisted surgery means improved visualization and access, particularly in areas that are poorly visualized and poorly accessed. What are some of the other areas that might be using robotic surgery? Well, certainly head and neck, and we'll get into that into more detail, but cardiac surgery is now using it, thoracic surgery is using robotic assisted surgery, gastrointestinal, stomach, intestinal surgeries, bypass, whatnot, hepatobiliary, Whipple procedure somehow have made the transition to robotic assisted urology. Prostate was really what brought robotic surgery onto the map to begin with, certainly continues to be a mainstay in this arena. Gynecology, hysterectomy is one of the most commonly performed robotic assisted surgery. Colorectal, now in the recessed area of the pelvis, is being utilized with robotic assisted surgery. Now breast, mastectomies are using robotic surgery to go in and really spare the important tissue and skin overlying breast cancers. Pediatric surgery, obviously with the smaller bodies, we need smaller instrumentation. Spine surgery, we're gonna skip over the bony robotic systems. We're going to talk strictly about the soft tissue robotic systems, but spine and neurosurgical applications are going to be critical moving forward as well as orthopedic surgery. Robotics assisted hip replacements and knee replacements are going to be really a standard of care very soon. So key point at this time in the talk is that head and neck robotic surgery is not synonymous with P16 or HPV related cancer surgery. It is by far the most common application as it stands, but even if you do not have plans to make this part of your practice, surgical robotics should be on your radar. You might say, prove it. I'm okay with that. Let's give a couple cases as how this might be in your practice. Well, let's give the case of the evasive tongue mass. A 62-year-old gentleman comes into my clinic with unilateral or one-sided tongue pain. And in order to evaluate him, we requested an MRI, which is shown at the top of the screen with the arrow showing some form of irregularity. So, standard of care, we bring him to the operating room. We perform biopsies of this area and ultimately came back as normal, certainly with no cancer, and we said that there's nothing to worry about. A few months later, though, he continues to have pain. Repeat MRI now on the bottom of the screen shows an enlarging area of concern or mass. What do? Well, we can consider to do another repeat direct laryngoscopy with biopsy, but that was shown to be not that productive. How about something externally, make a cut or some needle biopsy? Certainly possible. But why can't we use something to get us better visualization and better access to an area that's really hard to get into, deep soft tissue? Well, perhaps that might be part of your practice moving forward. What about another strange case, the case of escaping hyoid bone? An 82-year-old gentleman comes in, history of head and neck cancer with full course of chemoradiation therapy. He's experiencing recent increases in chronic throat pain. What you look with a camera in the clinic, we see this white structure sticking out into his throat. This is a hyoid bone sticking out. He's got osteoradionecrosis, a dead hyoid bone, which is extruding into his throat. What do we do at this point? To remove it from an external approach would require a soft tissue reconstruction, almost undoubtedly given the level of radiation, a fistula formation. How are we supposed to remove this bone, this dead, rotting bone for the patient? You can come up with some fancy endoscopic technique, or now that you're going to be familiar with robotic systems, simply take care of this problem for that patient. Well, the rebuttal is simple. Aren't these all zebra cases, meaning strange and unusual individual cases? You can't learn any real widespread rule of thumb with just these individual cases. And the truth of the matter is just like Chevalier Jackson here had a chart and bulletin board of all these strange foreign objects he was able to remove from patients' airways and digestive tracts. We too can have a collection of zebras, and the truth of the matter is this system, robotic systems, will not be useful in every case, but there will be unusual cases all the time which require advanced abilities. So now that you're sold, what is head and neck robotic surgery? Well, let's ask the FDA. And the FDA defines robotic-assisted surgical devices as ones that control and move surgical instruments through one or more tiny incisions in the patient's body, meaning minimally invasive, for a variety of surgical procedures. Right now, as the FDA defines it, there are two systems available that can be used for the head and neck for our purposes. The top one is the line of intuitive surgical systems. That includes the SI and the SP. We'll discuss the different systems in a second. On the bottom part of the screen is the Flex system from Med Robotics, and this is thought to be the true robotic assisted system, and that the surgeon is at the bedside controlling manually the instrumentation, although the use of the computer is inherent with the driving in of the camera system through the patient's throat. We will defer most of our talk away from the Flex systems, mainly from a pragmatic standpoint that it hasn't really shown the adaptation and adoption throughout the United States, and very few programs have this system. In distinction, the intuitive surgical systems are really found within almost every major medical center throughout the country. And so with that, let's discuss more about what the intuitive surgical systems might offer us. So the first one is the more tried and true system. The SI system offers a straight endoscope with 0 degree to look directly at our target, or an angled, meaning upwards 30-degree camera, which can give us different ability to see into our areas of the throat. These endoscopes have two lenses to provide some depth. It's not a true three-dimensional image, but it's what's called stereoscopic images. They offer 3 total instruments, but we can't fit 3 total instruments into the mouth with this system, so head and neck robotic surgery with the SI offers 2 surgical instruments, typically a spatula cautery as well as a Maryland forceps. Because there is still quite a bit of rigidity to the system, exposure and getting down and accessing some of the recessed areas of the throat still remains one of the largest challenges in our specialty. But nonetheless, the SI is across the board, across the country, the standard for head and neck robotic surgery. FDA approved release available for purchase is the Da Vinci SP system. This is the newest line from Intuitive Surgical, and what we're seeing here in the video is really a science fiction-like device which offers incredible amounts of flexibility, particularly in our uses, to get around tight corners and driven by the surgeon. We also have the 2 lenses from the camera, which provides that stereoscopic or that depth perception that is required for accurate surgery. Now we can get 3 surgical instrumentation through a very small space, so we can now have increased access above even the traditional robotic systems. But because it's so recent and so new, we really don't understand the dramatic effect that it may have for our specialty. So stay tuned. We're seeing some early reports from cadaveric work getting down into the supraglottic larynx, but how this is really going to change things, it's going to be up to us to determine that moving forward in the next couple of years. But it's here, it's available. Hopefully we'll see more in terms of what's available to perform with this system, but we'll, like I said, we'll just have to see. But very exciting stuff. So those are the systems, but what is head and neck robotic surgery? And it really is a computer-assisted instrument and tool to provide access and improve visualization to, or both, to an area that needs it. And I'll be hammering this point home because it's the critical point. It's a tool that goes into the toolbox just like any of our other surgical instrumentation. You need to cut some sutures, you use a scissor. If you need to access or see into a recessed area, we're going to call for the robot. where can this robotic surgery be applied in the head and neck? Well, many places. We're talking about the tonsil, where we're currently in an epidemic of HPV-related tonsil and tongue cancer, certainly the base or back of tongue to get around the corner. The upper part of the voice box, which is called the supraglottic larynx, can be easily accessible with either the SI or now the SP. The SI really cannot reliably get down all the way to the vocal cords themselves, but as we are going to see increased access with the new systems, the larynx and the vocal cords are going to be part and parcel of transoral robotic surgery. In addition, not only going further down in the airway, but we can go outside of the airway, removing things like the thyroid and other areas within the neck, either through the mouth or recessed incisional sites. We can also go up. The nasopharynx behind the nose is thought to be inoperable because of how morbid the approach is through the face, but now we can go through the mouth and reach the nasopharynx, not only for cancers but for other benign conditions. We can now start seeing some cadaver models being tested to see if the robot can go and do some advanced skull-based surgery as well. So we're just going to see how far we can adapt this technology to our patients' benefits. So, where is head and neck robotic surgery going? There's one answer. It's going up. This is one of the only graphs in our talk, but we need to show that in the last decade, not only in one payer database, but across the board, keeps going up. The indications, the comfort level, the accessibility for surgeons to offer robotic surgery to our patients, the number of robotic surgeries going up, in which case we all need to be familiar with what is the future uses or perhaps even future systems. Well, let's talk about the systems first. Well, from Medtronic, it looks like it's going to release in at least 2 years from now, maybe even longer depending on FDA clearance. They have this Hugo robotic surgical system, and we see the different components of this new system in the picture above. We're seeing the bedside console as well as the surgeon console, and really the surgeon console differs from the intuitive systems in that it is open. It doesn't require a hunched over position. Whether or not that's better or worse, that remains to be seen. We're also seeing the robotic arms are not part of one single bedside console, but they are individually able to move and adaptable. The thought is also you can upgrade one component as opposed to having to upgrade the entire system at every go-round. We also, because this is part of the Medtronic family, the Medtronic instrumentation is thought to be able to be easily adaptable to this system. So how this is going to play out, well, let's see, but we're looking forward to the increased competition in the marketplace, which will only drive costs down and increase access for our patients. Another exciting system is one that's called Sport Robotic Surgical System. This is out of Titan Medical, which actually recently also partnered with Medtronic. This is a company initially raised out of Canada. This is similarly in the same type of pathway right now, still in the very early stages of FDA approval. So we're looking at least 2 years away from market, but this differs from the Hugo system in that it's a single port, almost like that SP that we discussed. It has a much smaller operating room footprint and is supposed to be designed to be cost effective. Therefore, it's thought to increase community hospital and surgical centers availability for robotic surgery. This also has the same open display like the Hugo system. It's thought to be better for ergonomically for the surgeon, as well as allowing everyone else in the operating room better access to visualize what's happening from a surgical standpoint. The last system that really is important to be familiar with, at least the name, is the Perseus system from CMR Medical. This is a British company. Again, this is very likely going to be successful to be able to come to market. Not exactly sure where they are in the FDA approval process, them being centered in European markets. They may go through a different protocol in terms of their approach to their market. But this system design differs from the other systems that are up and coming, in that the hand control is thought to be designed like a video game, so that it can be freestanding from a console. Surgeon can be standing either away or next to the patient's side. There's also a modular arm system, just like the Hugo system. Also reported to try to be cost effective, as we're all trying to improve the access for patients to get their surgeries with robotic assistance. Okay, so those are the up and coming systems. What about some of the up and coming technologies that we need to be aware of? Well, the first one, which I think is very exciting as a surgeon, I like to have a dotted line cut here, and this is quite literally what this technology is going to provide us. Augmented reality is something that we see all the time. It combines 3D computer generated images onto live imaging or video feeds in real time. We've seen this when Pokemon Go was very popular. That has gone by the wayside. Back when American football was on television, the first down markers were augmented realities. But we can do this surgically as well. And now with the participation of computer systems as well as imaging systems in our day-to-day surgical procedures, we can now visualize 3D reconstructed structures of interest projected onto the patient's here real liver image during a surgery. And we're seeing the elastic registration process here of the imaging that was done preoperatively as well as the live feed, and that conforms and ultimately results in some pretty exciting ability to see better than just a bright light can. Along those lines, we're also seeing optical imaging. This is somewhat synonymous with near-infrared imaging. And so fluorescent guided near-infrared imaging can be accomplished with two things. One is the fluorescent dye, ICG, or indocyanine green, is a dye that's been used in medical applications for the last 70 years with the FDA approval. This is something when you shine a light that's just outside of the visible spectrum will cause the dye to glow. Can we use this non-selectively? We can inject this and it shows where increased blood flow or blood vessels are, but more exciting is some of the work that's being done out of Stanford by Dr. Rosenthal and his team, where we can combine antibodies directed towards tumors and combine that with the dye so we can see tumors literally glow in the dark. And so the photos here is one of Stanford's recent publications with sinonasal tumor. We see on the top the tumor looks abnormal just with white light, but on the right side of the image we see how it will glow when viewed with near-infrared imaging. After the tumor is removed, a little bit remains, and that can be confirmed with the use of fluorescence, and then after resection everything is dark. So again, we can now see in recessed areas with the use of robotic systems, but now with the adjunctive improved technologies we can actually see smarter as well. And so we're going to see that the number of benefits of robotic surgery is increasing, but there are some downside to robotic surgery, specifically the lack of haptic feedback. And that is relating to the fact that when we're using the robot, we cannot feel the tissues or what's going on. We can see the deformation of the tissue, we can see the softness, we can't actually feel it. This has given rise to a major field of research called haptics or haptic feedback. And that is this picture, and this is out of the UCLA Robotics Lab, where force sensors are placed on the tips of the instruments. That picks up how much force is being reapplied from the tissue, from Newton's laws of forces, that it will push back on the instrument. That will tell us how firm or rough the tissue is. That can then be relayed back to the console with pneumatic or balloons to the surgeon's fingertips. And that's a very exciting way to improve the surgeon's knowledge. And again, so some of the shortcomings that are still present will be quickly going by the wayside as well. But it applies to head and neck. Yes, it'll be nice to feel the actual tissues, but more importantly, in my opinion, is actually the haptics or the knowledge or the feeling of what's going on outside of the field of view. These are some artist illustrations and computer renderings of what happens during transoral robotic surgery as we're positioning with our SI instrumentation. The retractors in A, B, and C here are positioned in a way to cut out this base of tongue tumor. But as we see in the D frame here, when we go and start trying to resect this tumor, a lot of times the instruments will collide against the back teeth or molars or the jawbone or any other structure. But since our field of view, indeed the cone, is so narrow along the tongue base that we're unable to really understand or know why we're being hampered in our performance of the surgery. So what we are looking to do, in addition to a lot of research that's going on in haptics at the end of the instrument, is improve the haptics that is being applied outside the field of view. So here is our console that we were able to print up using our 3D printer. We've integrated sensing trays underneath structures like the teeth or the tongue or the cheeks, and this provides real-time vibratory feedback to our surgeons. And so we can not only learn how to do robotic surgery a little bit more precise and less traumatic, but also improve the outcomes. And what we were able to show to begin with, and there's a lot of work still to be done, is that when we provide our surgeons with increased feedback from outside their field of view, they're able to resect our quote-unquote tumors with a lot more success and skill. And so ultimately what we're seeing is that there's no question that 100% robotic assisted systems will be part of everyday surgical procedures. We can just count on it. We need to be familiar with it. We need to understand the up-and-coming technologies, some of the shortcomings, and how to address those. And even if we don't want to be treating cancer, not all of us can be cancer surgeons, not all of us should be cancer surgeons. So what do we need to do? We need to understand that if we have a problem that our patients are facing that really requires advanced technologies that we're comfortable and capable of offering to them. And with that, let's just keep this conversation going. Please reach out to me through the lecture site. You should be able to get my email as well, certainly on social media. I'd love to hear from you. And thank you so much for joining in on a lecture today. Take care.